The article for today's Journal Club is that was recently published in NEGM. I was attending the critical care conference in San Antonio when this was presented on the final penultimate, and that caused a lot of furor. That's the only thing I remember about the critical care conference. Rest was looked to me was for hospitalists. There is nothing much to learn there. So balanced crystalloids versus saline in critically ill. There was another patient, another paper came out simultaneously that was fluids in the ED and the floats basically. So before I start the Journal Club, I wanted to give you a brief background since 5 or 6 years, what kind of research was going on behind that made sense to do another trial. So as we all know that saline is the most commonly administered crystalloid, and its safety has been questioned in multiple trials, observational studies, because of the high chloride content that basically causes decreased renal cortical flow and maybe acute kidney injury, and subsequently leading to renal replacement therapy. So I will not go back more than 2012. I just wanted to focus on last 5 years, some major trials that came out. This was in NEGM again, August 2012, a multi-center parallel blinded RCT comparing ringer lactate with hydroxyethyl starch, and primary outcome measure was either death or end-stage kidney disease at 90 days of randomization, and they said there was increased mortality at 90 days and increased risk of renal replacement therapy. That was the difference. Next trial came in again in 2012. This was in JAMA, basically association between chloride liberal and chloride restrictive strategy, and again there was significant decrease in acute kidney injury, no difference in mortality. Then we have the next trial, in non-cardiac surgery. This was a retrospective study in non-cardiac surgery population in 2012. It showed that hyperchloremia group had increased risk of mortality at 30 days, increased length of stay, and risk of post-operative renal dysfunction. And we all know that hyperchloremia leads to poor outcome. Then Alveus trial came, I think after which albumin lost its favor. This was a multi-center open randomized controlled trial, like about close to 2,000 patients. Intensive care. Primary outcome was death from any cause, and secondary outcome was again renal dysfunction, organ dysfunction at 90 days. This was no mortality benefit in 28 to 90 days in septic patients using albumin with crystalloids or crystalloids alone. Then in May 2014, we have another randomized controlled trial, basically using 4% albumin versus normal saline. Then again says no significant difference. So I think subgroup analysis shows decreased mortality in septic patients. And this was the last major trial before this came. This was a split trial that was in October 2015 in JAMA that compared plasmolite to normal saline, and again there was no difference in outcome in acute kidney injury. So there has been repeated signals favoring balanced crystalloids, so that prompted the investigators to do maybe a very large randomized controlled trial to settle this answer finally. So before we start, I just want to briefly tell you about the composition of fluids, because we are talking about plasmolite, talking about ringer lactate, talking about normal saline. Just everybody of you knows it, but just to focus a little bit. So sodium content is the key here. Sodium is 154 in normal saline. Ringer lactate is low, plasmolite is low. Other thing is the potassium content. Then in ringer lactate, there is no acetate, but in plasmolite there is acetate, and we have lactate here. If you look at the osmolality, ringer lactate is almost 274. That's what our osmolality is like. So this study was conducted in Vanderbilt University Medical Center, and it is interesting to know that prior to the study, about close to 70% of the patients in the hospital received normal saline as the favored fluid for resuscitation, and only 30% of them received crystalloids in the ICU. Whether their practices has changed after the trial, we don't know. So it was a randomized controlled trial, pragmatic cluster randomized multiple crossover. And what happened is every month, the ICUs were randomized either to use saline or balanced crystalloids, alternating from month to month. It was an unblinded study. Everybody knew what the patients were getting, except post-cardiac surgery patients most of the units followed a very good protocol. There must be some close, overlapping, because there were some patients who got into the unit on, say, 30th April, and they got fluid, one fluid that day, and 1st May, because the calendar changed, so they got another fluid next day. They tried to do this as subgroup analysis, but there was certain group of patients that this happened as well. And it was intention to treat analysis. So another interesting thing to note was, initially when they started the trial, they thought that the sample size should be around 8,000, but middle of the trial, suddenly they realized that they wanted more beta power, so they increased the number of patients to 14,000, so that they have a 90% power to detect. And they also did multiple conditional odds ratio and other subgroup analysis on mechanical ventilation, pressure use, diagnosis, and everything else. So again, going back, so this was in Vanderbilt, Tennessee. So they have 5 ICUs. These are the beds in the ICUs: medicine, neurological, cardiac, trauma. And if you look at the supplemental index that they provided, I will show you in few minutes, is almost out of the 15,000 approximate patients they had, 10,000 of the patients came just from medical, trauma, and neuro ICU, and only 5,000 of the patients came from cardiac and one ICU. And the inclusion, everybody was included who showed up in the ICU. So there were a total of 15,000 patients randomized, and interestingly, as any trial we see, they were very well matched, and they initially decided based on the statistics that the predicted risk for death for group overall was 9.4% versus 9.56%, and the acute kidney injury was present in about 8.6 to 8.2% in the population. I will show you in the slide again. So this is how the trial started. All the patients who received in the emergency room over a period of 16 months, total enrollment was close to 19,000. So out of this, there were now split into half that went to the SALT ED trial, and the other basically, that went from the ED to the floors, went in the SMART trial. So SMART stands for isotonic saline and major adverse renal events trial. SMART should not be confused for, there is another SMART trial that came in 2012, that was salmeterol, multi-center research trial. That was 2006, I'm sorry. So there is 2 SMART trials, So because SMART trial in the pulmonary boards can occur because of the salmeterol trial. So this was the other paper that came out. We are not discussing this paper. This was balanced crystalloid versus saline non-critically ill, and if you look at the conclusion, they said that it made no difference basically if the patient goes to the floor. And this is from the supplemental index that I picked up this chart. If you look at here, 15,914 patients. If you see, medical, trauma, and surgical ICU, this accounted for almost 10,000 patients, and these 2 were maybe 5,000 patients. And if you look at the characteristics of the baseline, majority of these patients were, white race. Almost 18% of patients had stage 3 kidney disease or higher, and almost 50% of the admissions came from the ICU, and 14 to 15% of the patient had diagnosis of septic shock on admission. And as I mentioned a few minutes before, acute kidney injury was present in 8.6 to 8.2. So another thing about the authors was they tried to look back into the medical record and try to see, what was the baseline creatinine in the patients within last 1 year before they got admitted. So some of the patients didn't have any baseline creatinine record. So they used a formula to calculate the baseline creatinine approximately. So this is another thing, just to be aware of. So all the patients who went into the ICUs, as I mentioned, were allocated, plasmalite or ringer lactate. Most of the patients got ringer lactate, very few of them got, plasmalite. And another interesting thing about the trial is they gave the clinic physicians the option in patients who had hyperkalemia or who had any traumatic brain injury, admitting diagnosis or the diagnosis, they basically could they could prefer to use normal saline instead of using, as you know, that there was some theory in the past that this can cause problems, hyperchloremia can cause problems in traumatic brain injury. So about 7,900 patients were allocated to balanced crystalloid, and the total amount of fluid median volume was not much, like 1 liter. And the control group, that received normal saline had almost similar patients, 7,860, and here again the median volume was maybe like a liter. So volumes and rates were prescribed by all treating physicians, and it was up to the discretion of the treating physicians, whatever fluid they use whenever they wanted to change. And the ICU swapped their fluid allocation at the beginning of calendar each month. And a unassigned crystalloid was also available, like I told you, in patients with traumatic brain injury or in patients with hyperkalemia that they use. So this was the primary outcome from the result. So the major adverse, adverse kidney, what they call is MAKE, M-A-K-E, the major, adverse kidney event in 30 days. If you look at it, the p-value was 0.04. That was, kind of statistically significant. And the renal replacement therapy free days was 0.1. So looking at the other continued outcome, at discharge didn't make much difference. So this was the amount of volume, they used left on the balanced crystalloids, right on the saline. If you look at it, average volume was maybe about 1.5 liters, 1 liter, not much. And again, this was the plasma chloride and bicarbonate concentrations left in patients who receive chloride, the chloride levels. Of course, in patients who receive saline, where chloride levels were a little elevated and bicarbonate levels were a little low, as expected. So the primary outcome, what they mentioned was a major adverse kidney event at 30 days, was at 30 days was the primary outcome, and this what just I talked about, the p-value was 0.04. So I use this to just to play with little statistics and try to see if we are able to calculate, our absolute risk of reduction, relative risk, and also calculate the number needed to treat, from our side instead of looking into the article. So we have the numbers here on this paper. Based on this, we will do the calculation. So we have a saline group, that's control 15.4%, and balanced crystalloid is 14.3%. It's already told to us. So if you look at absolute risk of events in control group, that's 15.4%. It's 1211. I looked it from the chart, divided by 7860. So absolute risk for control group is 0.154. Absolute risk for treatment group is 0.14. So absolute risk reduction, this is a formula. I'm just using 3 formulas here, is absolute risk of events in control group minus absolute risk of event in control group. It's 1.1%. So absolute risk of reduction in this trial was about 1.1%. So the question is, is that significant? 1.1%. But the authors imply that we have close to 5 million people being treated with in the intensive care units in the United States. So in this trial itself, there were 15,000 people intervened. So if you are able to save 150 lives, it's significant. Each life is important. So they said even 1.1% is pretty much significant. So calculating the relative risk is, again, the formula is absolute risk in the treatment group by absolute risk in the control group. So it comes to 92. The number needed of treat, as we all know, is 1 divided by absolute risk of reduction is 90. 90 persons need to be treated to save 1 life, basically. So this was also, I pulled up from the supplemental index. Basically, this is what describes, the balanced crystalloid and crystalloid 14.3 to 15.4. So they did secondary outcomes later. This was, most of them were hypothetical, and they said that the recept of new renal replacement therapy persists renal dysfunction, but there was not much difference between the ICU free days, ventilator free days, vasopressor free days, after enrollment. And they did another subgroup analysis, 6 subgroups. Much of them didn't make sense except we look here now. So if you look on the left is the balanced crystalloids, on the right is saline. So except in cardiac and traumatic brain injury patients, maybe some shift to the right, most of them, especially sepsis, it made some difference. Most left them, the balanced crystalloids were better in almost all subgroups. So the author concluded that the trial involving critically ill patients, they favor administration of intravenous balanced crystalloids over saline to decrease the composite outcome of death, new renal replacement therapy, or persistent renal dysfunction at 30 days. So what are the strengths of this study? So one, if you look back into all the previous studies and this study, we have a sound clinical question with a pathological and experimental basis. That what they tried to address in this trial. And they do have a very large sample size here. That they hope that will give us the power to detect small differences. And they use composite outcomes. If there is something clinically significant, that could be picked up. And it was a very good design, randomized. There was complete follow-up of the patients. There was intention to treat analysis. And a mixed cohort of medical and surgical patients were used. That's, basically that's what we have. We go into the private practice or anywhere you have medical, surgical, combined ICUs, you have a mix of all patients. And they tried to separate the units, every unit have one type of fluid. Most of the time they were tried most successful except few instances that I discussed. And weakness of the study, it was a single trial, Vanderbilt Medical Center, 80% of the patients were, Caucasian, white, a BMI of 35, average age of 60.
Well insured.
Yes.
Well insured.
Well insured. So,
I don't think Vanderbilt accepts Medicaid.
Yes. So, if you look at that, if you look at that cohort of population, what the trial was conducted, and try to implement generally in, say, in Bronx, where I train, there might be some, problem.
Rich people benefit from regular lactate.
So, as I told you, there was not lack of, bias. Basically, they were not blinded, and the clinical, it was, clinicians should decide when to start renal replacement therapy. We don't know if there was a treatment drug. And again, as I mentioned, the trial only tells you to use plasmolite or ringer lactate, but doesn't tell you which one is better. And another thing, what I found interesting is the amount of fluids that the patients in the ICU got were pretty low, 1 liter total maximum. Like, if you know, at least 18% of these patients in this trial had sepsis as septic shock as a diagnosis. So, I have never seen any patient with septic shock just getting a liter or 2 liters. So, and another thing is, because the authors gave the open, option for all the clinicians to use, normal saline in patients with traumatic brain injury. Again, we don't know, we have no guidance what type of fluid to use in patients with traumatic brain injury. This one I already mentioned at the end of calendar month, like April 30, May 1st, it's possible that the same patient got 2 different fluids. One more thing, that I wanted to mention was some of the patients who got discharged from the ICU and got readmitted were taken back in the trial again. So patients got the fluid in the ICU, got discharged, then came back. They were re-entered the trial.
So they counted 2 times.
Yeah, 2 times, But they said they tried to do subgroup analysis, but that was muddy. I didn't understand that much. And again, I told you, they played around with the numbers. Initially, they basically had 8,000 patients. Then they realized, they wanted a good statistical result, so they jumped the numbers to 15,000 to see, because a bigger number might give them a big analysis. As all the subgroup analysis was just hypothesis generating only. So then I went back and tried to make some sense into all the major trials, that came in last 10 years, basically, that made some impact on the way the fluids were used in the, ICUs. So I'll just leave a minute for you to, see, except the split trial that was randomized, and blinded. Rest of them were unblinded. So going to the next slide. So just wanted to, briefly tell you that there is nothing normal about normal saline. It's called normal saline, but there is nothing normal. So, all of us know there is no physiological sense, in using normal saline. It's a hypertonic solution, it's a normal fluid solution. And we have had multiple papers showing, saline exacerbates acidosis. And maybe this acidosis leads to, maybe exchange of hydrogen, potassium, leading to sometimes hyperkalemia. And there has been many animal studies that have shown hyperchloremic acidosis, that causes, hemodynamic instability and increased inflammation. And we also know the saline causes, kidney injury. So since we have better options, it's always important and imperative to think of which fluids to use when a patient is sick in the intensive care unit, instead of just a knee-jerk reaction of ordering normal saline. So my conclusion, it is, as I told you, it's always better to use a balanced solution in critically ill patients. And the composite outcome, the statistical, analysis is very difficult to, analyze from this type of, trials. And as I mentioned, so far research has, at least bench research has clearly shown, that normal saline, and high chloride content can be harmful. So what we should do is think before we prescribe, IV fluids in the ICU. And I think all of us have to decide, to make a cultural change, and a new randomized controlled trial has to be decided. And there is one more coming up. This is called plasmolite versus saline. It's a multi-center blinded randomized controlled trial where they are using directly head-to-head with, plasmolite and crystalloids with a 90-day mortality. They have 8,800 patients enrolled in Australia and New Zealand, and results expected in March 2011. So they are continuing to do research on this area. We don't have clear-cut answers. There have been multiple papers, like I told you, almost close to 10 papers in last 10 years. Out of them, maybe 3 or 4 are significant. Most of the papers are directing towards one direction, that, normal saline might not be the best fluid to use in everybody. Until then, think what to give. Thank you.
What's the cost of lactated ringers versus saline?
Both of them are very cheap, sir. I think maybe like few dollars.
Few
Not much.
dollars.
Yes, few dollars. Maybe like
Yeah,
the hospital
multiply it by
pharmacy.
thousands.
The fluid itself is called like $3 or $4. I talked to one of the pharmacists here. They said $3 or $4. The problem is the tubing, the compounding, other costs. The bag itself is pretty cheap. That's
I
it.
think a very few cent difference between the.
Yes, I mean, the
It's
total
plasma
cost
light-
is like,
Will was saying plasma light was like $1.50 more than that.
Yes,
but
something.
that's also not very expensive, but a lot of normal saline, there's few cents kind of like, yeah.
both of them cost less than $5, I know, for
They're all
sure.
made in Puerto Rico, aren't they?
Possible.
Aren't they having a shortage of that stuff after the hurricane wiped out
Yes.
Puerto Rico? Some resource that's frequently used, I can't remember, it was IV.
The question is this maybe small mortality improvement also going by less amount of fluid use? Because, I mean, we have all this evidence suggesting more is bad and septic shock and here like you see eye-popping difference in amount of fluid, 1.1 liter to
Did they
3
get
to
any
5
fluids
liter.
in the AD? Like,
Yeah, we give-
this was just continued to the ICU?
Yeah, this was the total, most of the patients' average stay was close to 7 days, if you look at the thing. So it's surprising, like about you have 18% of septic shock patients, average in the trial. And people have stayed for 7 days, and the whole overall they got 1.2 liters,
I mean, that's
1.5
actually
liters.
Vanderbilt, it's a good practice,
Yes.
kind of like that.
True.
I mean, why not less fluids and the appropriate fluids together? I mean, yeah. that's all.
I heard they pull fellows' nail out for prescribing saline.
No, I mean, the question to ask is, your conclusion is right, the question is, so leave aside whether LR is better than saline. Why saline? Why our go-to fluid is saline? What evidence do we have to use saline that we are using so far?
Cheap.
I think the problem is between trying to give volume, versus resuscitation. There is a difference, when you're trying to resuscitate somebody with a hypotensive shock, you know, versus you're trying to just replace volume of fluid in somebody. So I think when it comes to trauma and resuscitation, I think when the patients needed, you know, more volume, I think at that time they started using normal saline,
But-
probably.
But there's no physiological sense.
No physiological sense. But this has been like a cultural thing going on since all the trauma trials that in 40s, 50s, you know, maybe normal saline was more available at that time, I don't know. So it became more of practice, what my professor taught me, I'm going to use the same.
But don't you see like surgeons using way more LR than?
Yes, true, this is true, another thing. Like if you look, we work in surgical units here, you know, like trauma, ICU, for them the go fluid is allowed everywhere.
Yeah, that's the only thing I agree with surgeons.
Surgery teaching.
Yes.
Dr. Dalbano, when you're resuscitating hypovolemic shock and using saline, how much goes intravascular?
Probably
1/3.
I thought a third, a
10%.
third of it goes intravascular.
10%.
What's that?
A third.
10%.
Right.
Only
Use
10%.
D5W, how much goes intravascular?
All of it?
10.
Pardon me? All of it goes intravascular, D5W?
It's free water.
Not a, like very little of it. It's like
Maybe
50
no,
cc's.
Less of it, maybe 10%.
Yeah, very little. Why they put D5 and D5W?
It drives the fluid in inside the
Pardon me?
cells, right? I
To-
thought the glucose
Why they
drives.
put the glucose in?
To prevent hemolysis.
Yeah.
Allegedly.
Right.
Allegedly. I think you
Put
can
water
I think
in
you can
it,
give sterile water
right?
just fine.
It brings the osmolality up, so it's not, you're not lysing red cells.
Okay.
You can go back to that previous, where you compared. the-
Nobody uses hetastarch anymore, do they, or do they?
No.
Mm-mm.
No.
This
Bleeding
one.
issues?
There's
They
a,
can't hide,
there's a,
Synthetic potato?
That was mainly in Australian practice.
there's a recommendation against now.
Australia.
They use it?
They were using it.
Yeah.
The studies, yeah.
Yeah.
But did you ever use in US?
The
Like,
script is
Hetastarch?
probably waiting on some
Yeah, it was used for a while, but, you know, there were
Right.
studies and, you know, people had trouble bleeding and that kind of thing. It never worked out to be any better than saline or anything else.
You got your little list back there?
Albumin.
So I think the interesting study would be to take like rhabdo patients or burn patients, you know, like the crucible, these guys that are getting lots of fluids, and look at those and see, because any differences that may be there might be a little more pronounced in those guys.
I think I ought to do a DKA study, because we used to use saline DKA. all the time.
We've already, I don't know about these other guys,
Hyperplasia as
but
hell.
some of us have already started
Probably
using
taking-
LR in the DKA patients.
Yeah, I'm just wondering, is there any difference? Because, I mean, most of those young people had chlorides of 115, 120, and, you know, you wonder if it's harmful, or if maybe it's doing good because it's keeping the potassium out of the cells so you don't drop your potassium.
It's not making a difference because they're not gonna take their insulin when they leave anyway, so
They're young.
delaying.
I think the problem is the IRB, you know, patient safety boards will not approve this type of a trial.
No, but we know that it might anecdotally, it increases length of stay in the ICU because you're
Yes.
converting a gap acidosis to a non-gap acidosis.
Yes.
Your bicarb remains low, and then you would not, the gap has closed, and then that will prevent, kind of like that stuff, so.
Thank you, Mandy.
So it's like,
NHIM
I mean,
starts
you should tell
complaining.
PD to start using LR on all, kind of like, instruments.
Well, we just start with insulin.
Yeah, I mean,
Yeah.
Like,
But
like, what's
that-
the,
He asks.
what's the one thing that increases mortality in ICU? One thing you're trying to prevent that increases mortality?
Renal failure?
Yeah, AKI. So
AKI.
anything that can prevent your AKI or help with that, I think that would be best in terms of your ICU patients.
And I think it has been kind of personal experience too. However sick the patient is, how many pressures the patient is, if the creatinine is normal, he will survive. Once the creatinine goes up, you know, the mortality goes up. That's my thought, observation, I'm not, you
Yeah,
know,
that has
telling,
been
yes,
proven also.
observation, you know, once the kidney gets shut, then it's indirect, you know.
I think it's, you can handle one failed system, two failed, when it's three failed system, then it's time. So you can have any of the one, liver, heart, or kidney. You can work with that, when there are two,
So in the neurosurgical unit, we're gonna start using 3% LR?
the saline which is rebranded like that.
You gotta come up with a new fluid. I mean, all you have to do is get a new fluid approved and show us better than something else. You'll make tons of money because so much fluids are used, right? Look how much salines used, you know? Using some kind of fancy chemo, that's very few patients, but look at all the number of patients.